I'm ready. Sir, over to you now.
Thank you, Mr. Rajesh from Bayers. At the outset, I would like to thank the Bayers for giving the opportunity to have with me all the panelists, reputed panelists from our country, to have a very good, useful, very clinically important panel discussion on CSF rhinorrhea, which is very, very important for any aspiring endoscopic sinus surgeon, be a resident or a consultant or otherwise. Now, I take this opportunity to introduce my elite panel of today's evening, Dr. K.R. Megnath and Dr. Pawan Singhal and Dr. Dhubro Rai from Kolkata. Before I introduce, I take this opportunity to thank everyone involved in this webinar, and I welcome all the delegates on Saturday evening. And Dr. K.R. Megnath doesn't need any introduction, but he's the founder of Ma ENT group of hospitals, and he had an enormous experience of conducting over 60 workshops on various subjects in ENT, namely the endoscopic sinus surgery, micro-ear surgery, and recent advances in ENT specialty. He has been a national faculty and international faculty for many, many live surgical workshops and delivered many orations. And Dr. Megnath is fascinated to acquire latest technologies in ENT, and he is a wonderful endoscopic sinus surgeon as well as a micro-ear surgeon, the intact bridge mastectomies, and then the cochlear implants. And he has done more than 600 implants at Ma ENT Institute, Jubilee Hills, Hyderabad. And he is fascinated with the latest technology of the ablation and the image-guided systems. Next, I introduce Dr. Pawan Singhal, who has been the professor of the reputed SMS Medical College, Jaipur, and he has an expertise in endoscopic sinus surgery and skull base and head and neck surgeries. And he's also a cochlear implant surgeon, and he's an award winner from Johns Hopkins University for tobacco control. And he has been awarded the best research paper by the American College of Surgeons. And he has won many awards, and namely the award from the Governor of Rajasthan for a best doctor, and then State Medical Council of Rajasthan. And he has presented more than 35 publications in national and international index journals. He has been a guest speaker for various conferences and congresses. Then I welcome Dr. Dhubro Rai from Kolkata. He has been a senior consultant for Amri hospitals in Kolkata, and he has expertise in using the modern tools like laser and ablation and microdebrider, etc. And he is an experienced endoscopic sinus surgeon for more than 15 years, and he is well versed in skull-based surgeries, and he is trained in Spain for temple bone dissections. And then he has organized several workshops on sleep disorders, radiology in ENT, and then endoscopy of otology. And he has been a life member of International Working Group of Endoscopic Ear Surgeons, and also the member of Association of Phonosurgeons of India and Laryngology and Voice Associations. Now, with this introduction of my elite panel today, I request all the panelists to be reasonably quick in answering all the questions and give a good comprehensive text of going ahead with the CSF rhinorrhea repair. And before I start my panel, this panel discussion excludes some of the very, very large skull-based resections. So today's panel doesn't include any tumor excision from the nose or from the brain, and do a large reconstruction. Those things are excluded, and all the basic essence of managing a case of CSF rhinorrhea in your clinical practice with all the basics. Now, quickly I proceed to my first question. So, what are the causes of spontaneous non-traumatic CSF leaks? May I go to Dr. Pawan?
Yes, sir. So, mostly these spontaneous leaks are maybe congenitally leaks, which may be due to there is some defect there in lamina in the cryptiform plate at the lateral lamina, where the anterosphenoidal artery enters, or maybe some defects in the lateral sphenoidal wall, where due to constant pulsations of the arachnoids gives rise to thinning of the bone down there and can give rise to leaks. Mostly seen in middle-aged females, obese females, and in perimenopausal females who has gone through osteoporosis, or maybe some cases of osteomyelitis, or some vitamin D deficiency and other syndromes are there. And a few cases can also be seen in elderly who has got some bone remodeling diseases, some devastating diseases which are involving the bones. I think these are the main causes for spontaneous leaks.
Does anybody can comment on relationship of OSA with the association of CSF spontaneous leak?
I would like to...
Yes, Dr. Meghna.
Whether the relationship between the OSA and the CSF leak, keep it aside. The most important thing is if these patients go for a CPAP, that is a disastrous, and they will develop, in no time, they develop pneumoencephalus.
So that is
very dangerous. Be careful.
That is because of raised ICP?
Yes.
Yes.
And because of vasodilatation, cerebral vasodilatation followed by the congestion and then raised intracranial pressure.
Yes.
Does anybody have order any vitamin D assay for spontaneous leaks?
You're supposed to do it.
You're supposed to do it.
Yeah,
and you go for long-term therapy for spontaneous leaks if they have vitamin, because most of us are having the vitamin D deficiency. So does the CSF leak after repair, does they go for vitamin D treatment or calcium treatment for lifelong?
We usually take the opinion of an endocrinologist in these cases, and I've seen that they put them up for a long time on vitamin D supplements. They are doing it, yes.
Okay. Then what is your diagnostic protocol? May I go to Dr. Roy? Sir, what is your diagnostic protocol with reference to the two things? That is CSF analysis.
Well, if I am suspecting that it is a CSF leak, then there are two things I would like to do. One is the CSF glucose level, and the second one is the beta-2 transferrin. These are the two things which I will go ahead and do.
You do beta-2 transferrin for all the cases?
The glucose test may be sometimes, no, not usually, if the patient can afford it. Usually I do only the glucose test, and other things are clinical suspicion. I usually avoid the beta-2 transferrin, and I go straight away for the gold standard, that is the CT scan. Go for HRCT. That is the next step. First step is the CSF assay, the glucose level, and then I go for the CT. These are the two things I always do. Beta-2 transferrin rarely, if the patient can afford it. Otherwise, I don't.
Can anybody highlight the advantage and disadvantage of beta-2 transferrin testing? Any advantage or disadvantage of beta-2 transferrin?
I can tell that.
Testing.
Beta-2 transferrin is very specific and very sensitive. But, and of course, small errors can be there in some cases, cirrhosis of liver, or say beta protein secreted by some Europeans, or some sort of amine cycle disorders. But usually it is very accurate.
But how much time will it take to report, sir? How much time will it take the lab to report?
Usually it is taking 5 to 7 days. In Kolkata, they are doing it. They are giving it after 3 days. I don't know whether they are valid because they don't have any support from the US FDA. So whether it is valid or not, I don't know. And it's very expensive. So most of the patients avoid that, and we also avoid that. That is the expenditure is the main issue, and the time, the delay in getting it. But it is 100% confirmatory.
Same with Dr. Same with Dr. Megnath and Dr. Singhal.
Same, but I prefer beta trace protein assay. That is more reliable and more, that life is more.
But we don't do it routinely in our practice.
We don't do it routinely. Absolutely right. We don't do it routinely. What I do is I take the CT cystoscopy as a gold standard.
But do you see any medico-legal importance of beta-2 transferrin?
Yes, definitely. There is a lot of importance is there. But if the CT cystoscopy shows the leak and the dye is noted in the cotton, they keep it in the vestibule of the nose. If that is soaked with dye and radiologically it is positive, that is confirmed that there is CSF rhinorrhea.
Sir,
Yes.
like the most advantageous thing about beta 2 transferrin, I think, is its 100% negative predictive value.
Excellent. That's correct.
Yes.
Yes, sir.
So it excludes the possibility of CSF if it is not positive.
It's a nice point to be noted, sir.
Yes. But honestly speaking, I have only ordered it for 2 patients out of my
Yes.
maybe 135, 140 cases I have done so far.
Yeah, we can hardly remember at least 4 or 5 cases in entire series of nearly 200 or more than 200 cases.
Yeah.
Yes,
But
sir.
mostly we carry on with the CSF analysis with a typical defect on the CT, so
Yes,
that we can easily
Because
support our
honestly,
diagnosis.
It is not available. The report comes late, and usually it is not required that much.
Yeah,
Most of
but in Western literature, in Western countries, there are several institutions all over the world. There are several institutions where the beta 2 transferrin is a must
is a prerequisite. Yes.
before going for surgical management.
Yeah, it is there.
Yes,
Yes.
and
There are. I think so. There are something more is there. One
Yes.
more important investigation is there is a rapid chip-on immunosubtraction technique, which gives the results within 5 to 10 minutes. But I think it is not available there in India and not available
Not available in India.
countries.
we are not aware of it, sir.
Yeah.
Then I think Dr. Singhal, what is your diagnostic protocol with regard to imaging
Imaging, sir. So
a suspected case of
the way
CSF?
we have started, we had to at first confirm whether it is CSF. We have done that.
Yes.
Now we have to localize the defect. That's why
Yes.
imaging is required. So my protocol for imaging is CT. If I'm sure about it is CSF by my clinical acumen, by the history and examination, then I'll directly consult the patient about CT cysternography. But I'll say him that it is invasive technique. If he is not ready for that, I'll subject the patient to MR cysternography. So this is my protocol of doing diagnostic testing, sir.
Dr. Meghnad, do you differ?
Yeah, the same thing, but I would like to do the MRI to rule out any tumor and benign intracranial hypertension. And one important thing, and what I do always is when the patient goes for CT cysternography, I request the anesthetist who is going to do the lumbar puncture to measure the CSF pressure.
Yes.
If it is more than 15 centimeter of water, then I have to be a little more careful. I have to give a little guarded prognosis, and also I have to tell the patient that he may require a thicoperitoneal shunt. So this is only just a management thing, but MRI is a must, not cysternography. MRI brain to look into any causes like tumors.
But the only disadvantage I find with MR is a few cases of spontaneous leak which are intermittent leaks.
Yes.
Yes.
If they are intermittent leaks and the time of MRI, if it is not leaking, then it
Sorry.
becomes a problem.
Sir, MRI is to exclude the other conditions, not
Yes.
the diagnosis
Intracranial.
of rhinorrhea.
Yes.
To exclude the other issues.
Yeah. So you require both the things.
Yes.
Sir.
See,
So in a
cysternography is a must. Unless it is contraindicated, then I will do MR cysternography.
Okay, sir.
But the disadvantage of MR cysternography is only you get a positive when the leak is active.
Yes,
Yes,
absolutely right.
And I think now for imaging, HRCT plane is the choice number one investigation.
Number one
Right?
investigation.
Pardon?
Yeah.
Yeah.
Agree.
First thing.
And you, when you are ordering for HRCT plane, you also tell the radiologist, if you don't find it, you go for contrast as well.
Not here. In our protocol, we don't. In our protocol, we straight away go for MR cysternography. After
So if the radiologist doesn't find HRCT plane,
You go
no
for
defect
MR
anywhere, then go for MR.
that, we go for MR cysternography. That is
MR
our protocol in
cysternography.
our hospital. Yeah.
But the disadvantage of MR cysternography, only you get a leak only when the
Yeah,
leak is
that is
active.
true. That is true. That is true. That defect is there. Yeah. That problem is there.
So HRCT coupled with MR cysternography as the choice
add both.
investigation. Yes, sir.
When you add
Add
both,
both.
it is very fine.
But
Yeah.
there is, if you ask, sir, only
Yes.
one diagnostic modality, then I think CT cysternography comes at the upper end.
Undoubtedly.
Yeah.
CT system. If you want only one investigation, that is CT cysternography.
Yes, sir.
Yeah. So if you want, it's better to have HRCT plain and MR cysternography. That is a choice.
Yes, sir.
Then anybody has the experience of radionucleotide cysternography?
No, sir. I don't have.
So anybody has experience of fluorescein dye?
Yes, sir.
What is
I do have
what
that.
is today's place in CSF rhinorrhea management?
Sir, can I speak?
Yes, yes.
Sir, in 2 cases till date, I have used fluorescein, in which, because I always keep fluorescein there with me. When there is a problem with identification of the leak on pre-operative imaging, also, always I have seen this difficulty with spontaneous leaks.
Yes.
So if you don't find a leak there in the OT, and you have lowered the head for maybe 15-20 minutes, you have said your anesthetist to do a Valsalva,
Yeah.
you have seen glistening surfaces inside the nose, everything you have done.
You raise the CSF
You have not
volume.
found.
Yeah, you raise the CSF volume, Valsalva, all those measures have
All
not
those things you have
yielded.
done so far.
Then you go for fluorescein.
Then I'll go for fluorescein dye testing, sir. And I take a consent of the patient pre-operatively.
Yes.
That is, I might
For
have to
possible
use
reactions. Possible
it for
reactions.
side effects.
Yes.
Yes. Anybody want to add about fluorescein dye test? Any critical comments on that?
It is very useful in post-traumatic CSF leaks. When there are multiple leaks, it is very useful.
Yeah, when it is multiple, now today's limitation is when the fluorescein is very useful in multiple leaks. And also, if you repair those multiple leaks and do again a fluorescein and see whether your leak is perfect or not.
Yes.
So in that situation also, fluorescein can help.
Yeah.
Intraoperative assessment of good sealing can also be assessed by fluorescein.
Yes, sir. Even Dr. P.J. Vermold also emphasizes on that.
Yeah.
Do a dye test after he has repaired the things.
Right, sir.
This
And
fear
fluorescein.
this fear of fluorescein
Yes, sir.
is
You want
more,
to add something, sir?
this fear of fluorescein reaction is much more than actually what happens.
Yes.
This is being routinely used by our neurosurgical colleagues in my neurosurgical unit regularly. I am not using it in my ENT, but regularly these people in neurosurgery, they are using it at the drop of a hat. And till date, there has been no problem. The fear is more than
I want to add
actually what
here,
happens.
the fluorescein dye is notorious to cause epilepsy, grand mal epilepsy.
That's true. That's true.
And when it is solely the dose related. If you use a
Very
low
high,
dose, nothing will
no
happen.
problem. Nothing will happen.
But if you are dose related, if the dose is high, and probably the epilepsy is more, and that's the reason why FDAs are not approved.
True. Very true.
Important point is there, sir.
Yes, sir.
Now I have stopped using that because I have seen that if you don't find any leak, then try to go to the cribriform plate, lateralize the middle turbinate a bit. You will find a small meningocele there.
Yeah, that will come. Will come later, sir. That will come later. That will come later because we are now discussion is confined to only the intrathecal fluorescein.
Yeah.
What is the present day status?
Yes, sir.
In our practice? Now coming to iatrogenic leaks, Dr. Roy, how to avoid during FES? Because more and more FES surgeons are emerging, and the iatrogenic CSF leaks. Yes, sir.
The pre-operative assessment of the patient, especially the
CT scan.
radiology. Yeah, the radiology colleagues are very helpful. You have to assess the anomalies in the CT, the classical anomalies like the depth of the cribriform fossa, the Kiros classification, if there is any problem with the lamina papilla, if there is already any break in the cribriform or any other bony dehiscence, these are to be planned before. We have to know the area of the frontal cells, how is the layout. If we know the areas which are create a problem, then we are prepared.
Yeah,
pre-operative
assessment is the important, and
a nasal endoscopy to see the anatomy inside before the OT.
Yeah.
And to have a plan of action that what I'm going to do in the OT. If plan A fails, then plan B. We have to be ready with the plan A and the plan B. If these two things are followed, usually the iatrogenic leaks are usually less. And the OT during the OT, the preparation of the patient is also very important. Like your pressure, the total map, the proper use of the anesthetic agents, the proper decongestion of the nose, and the proper placement of the instruments, the proper
Surgical
handling of the
technique.
instruments.
Surgical technique.
The techniques are
And
very
especially
important.
in revision cases, you should be very careful. If you are good enough, you can
Landmarks are
handle.
lost.
Otherwise, you take the help of seniors. And even the seniors also require sometimes IGS to prevent this particular complication.
Probably the navigation system helps to some extent, but there are some fixed landmarks which are never lost, even after a revision surgery. If we are aware of the landmarks, the non-lost landmarks, like the maxillary ostia, the lamina papiliaca, the septum, probably a small stump of the middle tablet. These help you where you are actually. So even the revision cases also we can handle, but we have to be slow and very slow and steady. And of course, as you told, the senior most surgeons should attempt it. You are very right.
Yes.
And these are the ways of handling.
I would like to highlight one point here. One is the entry of the entorrhinoidal artery and neurovascular bundle. At that point, the skull base,
the thinnest portion of the skull base.
Yes, always.
Everybody knows that. I will tell you the second point, where the posterior ethmoid merge into the roof of the sphenoid sinus. That is another point. Is another commonest site of
anterosuperior aspect of sphenoid sinus.
Yes.
Yeah.
And one important thing is, in fact, I encountered this when one of my colleagues is operating. The neck is little more extended. So when the neck is extended, what is happening? The posterior ethmoid roof, skull base, is down.
Slopes down.
And he thought that is an ethmoidal cell. And so this is, I always now tell my residents, keep the head in the correct position. That is a very, very important thing when you are doing a sinonasal.
So the preoperative radiology assessment of the disease, and then the limitations of the surgeon, how far he can go, and availability of IGS, and then position of the patient, the bleeding aspect of it. Sometimes the bleeding is more. If you are lost, don't dig in the pool of blood. You have to stop it and take the help of seniors.
And abandon.
Abandon.
One more thing about what I teach to my residents and junior colleagues is to be medial and inferior.
Always. That helps.
Down and medial. The mantra for juniors is always down and medial.
Yes. And the second point is microdebrider is very dangerous.
Yes.
For the nail surgeon. So they have to use it very judiciously.
Yes.
Because it can take small fragments of the bone from the skull base, lateral lamella anytime. So
if you are not seeing anything in the pool of blood, don't apply the microdebrider.
Yes. So that is judicious use of microdebrider should be taught to them.
Yes.
Any powered instrument.
Yes.
Should be careful.
Now the same Dr. Pawan. Pawan. Yeah. Yes. Suppose you encounter during surgery, of course, you try to seal the leak. But if you take out the pack after 24 hours or 48 hours, if you find a CSF leak post FES, so what are you going to do?
So for the protocol which I follow is if within 7 to 10 days, I find a leak, I would try to give a conservative management to operated case.
No, this is a specific question, sir. After removal of pack.
Intraoperatively, I found I'll operate again.
That of course.
But after removal of the pack, if I find that, I'll not just mug up going operating. No, I'll hold it for the conservative management.
You want to go for medical management, wait and watch?
Yes, sir. Medical management with wait and watch for 7 to 10 days.
Anybody differ?
Yes, I will differ.
Yes, sir.
I would like to say something.
Yes, sir. Go ahead,
In this case, of course, I will try to medically manage the patient with acetazolamide and a lumbar puncture, but I would go for a immediate CT scan to see whether I have done the mischief, whether I have removed any bony fragment or not. I will not wait for it. I will not wait for it. And if I see
you go for imaging immediately.
Yes, imaging immediately with plus the medical management.
You assess what is the size of the defect.
Yes, that's the size.
So what will you do with that?
If the size is small, and my medical management is already
Small is how
in
much?
place.
How much
Less
is the small?
less than 2 mm. Less than 2 mm.
Less than 2 mm, you would like to wait.
I'll wait for 5-7 days.
And give a medical management.
Medical management, yes. And a lumbar puncture is a must. LP, I'll try to drain the 150 ml of fluid per day, maybe.
Okay.
And
okay.
give acetazolamide and
Dr.
wait.
Megnath, you want to differ?
Yes. What I will do, I will go back to the theater recording video and go through the video and
assess yourself.
Where, yes. Apart from the CT scan, I will do this also. Then I will take the patient into the theater and I will identify the leak. I'll coagulate that mucosa and put a middle terminate mucosa there. And
so you want to do diagnostic nasal endoscopy immediately?
Immediately and
under general
anesthesia and close the defect.
In the same day.
Very simple, very simple. Here, don't try to do the underlay, just overlay. Usually, if it will be very small defect or a fracture in the.
So, irrespective of the size of the defect, so on the same day as the leak is present, you want to take the patient into theater and do a diagnostic as endoscopy, just like a surgery. If you find a leak, irrespective of the size, you want to seal it.
Yes.
You want to seal it without imaging. No conservative management.
No. Imaging I will do. I will not wait for the conservative management.
Imaging when you do, if the leak is very small, is it not worthwhile giving a medical management?
No, sir. I would like to, because the risk of meningitis is more in the post-operative cases. Because the nasal cavity is full of bacteria. I have done the surgery for the chronic sinusitis.
Here I want to make one point, apart from all the three panelists have answered. If the leak is a high pressure leak, if it is dripping like anything, very fast and high pressure leak, probably that needs immediate surgery.
Yes.
And if it is leaking very occasionally, little bit of dripping, now again after half an hour or 1 hour, and these are the cases worthwhile giving medical management. Yes, sir?
Yeah.
Agreed.
Now we'll go to next question, sir. In general, if you consider medical management is basically for spontaneous leaks or traumatic leaks. Medical management is when? For spontaneous leaks. Do you give spontaneous leaks a medical management? No.
No.
Usually for traumatic.
Usually for traumatic.
Yes.
But if the spontaneous leaks comes only a days, or 4 or 5 days or 1 week, you can still give a medical management.
Yes.
Yeah. And traumatic leaks, sir? What is the controversy of the traumatic leaks of medical versus medical management?
But in the traumatic leaks also, the current concept is repair at an early date. See.
How early? How early?
What is the ideal time of repair? There is no emergency, but repair as early as possible. Plan it and do the repair.
What do you mean by early? How many days? Days, weeks? I want days and weeks.
Days.
7 days?
And see, the reason is all skull base fractures, the dura will not be healing. The dural seal will not happen in all the traumatic leaks. So what happens is the nasal mucosa bridging happens, and that the nasal mucosa closes the leak. And the fibrous tissue formation is the second thing. The fibrous tissue formation in the skull base fractures is not very strong. So if you look at the current Scott Brown also, the literature says that in the long-term follow-up, the risk of meningitis is up to 20%. And the meningitis is always associated with higher morbidity and mortality, even in the current era of antibiotics. So, even in the post-traumatic leak, the ideal thing is to repair it. And when you repair, this forms a strong union.
Anybody want to differ or add?
I differ there.
Yes.
So 80% of these traumatic leaks, they heal on their own.
Absolutely right.
Yes, absolutely correct.
Yeah. So I think we can give it a conservative treatment for maybe a few days. Even after that, 7 to 10 days. Even after that, if the leak is going on, we can repair. One thing is that. Second most important thing is imaging.
Yes.
If on imaging of a trauma, we find bony spicules shattered down and displaced, then these cases should be repaired.
Yes.
But in cases where only...
That's a very valid point, because if you find a bone is
Sorry,
pupule,
I would like to highlight that. Please,
Yes.
the point here is, in the long-term follow-up, you follow this patient for 20 years, 10 years, the incidence of meningitis is very high, because the communication or the path between the nasal cavity and the intracranial cavity is
so
a very thin
overall incidence of meningitis in all
is,
traumatic cases is about 11 to 20%, which is quite high.
Yes. But if the bones are in close approximation,
Yes.
they will heal on its own, and the bone remodeling would happen that will seal the things.
So if
the
there is a...
it doesn't happen.
Yeah, I think your point is well taken.
If you look into the latest literature, this says it doesn't happen.
Okay.
See, the skull base doesn't heal by fibrous tissue formation. It doesn't heal like that. The fibrous tissue formation between the two fragments of the bone and the skull base is very, very less compared to the rest of the bones.
Yes, sir. I think traumatic CSF leaks have evoked a lot of controversy all over the world. The thing is, the incidence of meningitis is very high. That's why you have to close as early as possible, giving a reasonable attempt to medical management, because most of the, up to 90% of the traumatic leaks, they heal spontaneously, and whenever possible, the time limit should be cut short and you should repair it, because once you develop meningitis, it may lead to intracranial complications. So that's about the message, the take-home message, sir, and we'll move on. And this is a medical line of management. Anybody want to add anything? Because the patient, the head-up position, avoid straining procedures, acetazolamide, antibiotics, and lumbar drain. So you want to add anything? Yes, good enough.
A very important point is, don't try to give mannitol to the patient.
Yeah.
Because it shrinks the brain and it gives more space for the leak to happen. So mannitol should never be tried in these cases.
Even the post-operative protocol, when mannitol is not there?
Mannitol should not be there.
Not be given.
And acetazolamide, how long one can give, sir?
Sir, I prefer...
It has no value.
Yeah, as such 3 to 4 weeks I give my operated cases.
3 to 4 weeks.
Doses. 250 milligram thrice a day, then twice a day, goes for 2 weeks. At first twice a day, 2 weeks, then twice a day, 2 weeks.
Okay.
And this Gardinal I don't use, sir. I don't use any anti-epileptic until unless a large part of brain is
Gardinal has got the neurosurgeon feedback is Gardinal has got a double role. Number one is it is anti-epileptic, and number two, it reduces the CSF secretion from the choroid plexus.
Okay.
So in fact, it reduces the pressure of CSF by decreasing the secretion of the CSF itself.
Okay. But in those cases where a large meningoencephalocele is there, I use that. Otherwise, I don't use it in plain CSF.
Not in routine cases. Okay.
Not in routine cases.
Now, sir, there is some peculiar situation where in a case of intermittent leaks, thing is 1 week he leaks, another week he is all right. So these cases, I have one case where the imaging also didn't help me. So how to go about intermittent leaks with the imaging saying nothing, there is no defect? How to approach these cases, Dr. Meghnad?
Yeah, reduce the head level and Valsalva maneuver. That's all. These are the two things.
So, no.
And other thing is you can do a lumbar puncture, inject some ringer.
No, in case where the obvious defect is not there, and the patient still gives a CSF leak intermittently. So we have to explore endoscopically.
Yes.
And what I would prefer is, the most common 90% of the leaking area is a cribriform. You expose the cribriform first.
Yes, sir.
And see whether leakage is there or not. If not, explore fovea and also entire skull base.
Yes.
Yes.
Is it okay?
Yes.
It happened in one case to me. Yeah.
I'd like to say something.
Still, if there is no leak,
yeah,
then you have to go with endoscopic carpeting, like what neurosurgeons do from top. We do anticipated area.
When the leak is unidentified, leak is unidentified, there is the sole criteria for an intracranial approach is when the leak is unexplored. Even in Scoutbound it is said. So you have to approach it intracranially, not nasal endoscopically. The only criteria for intracranial approach is an unknown site of leak. And I think we have to take the help of the neurosurgeon along with you. Rather than poking around in the kidney trauma and the phobia, I think the intracranial approach should be taken.
Dr. Roy,
That is written in
Dr. Roy, this is not poking. What Venkatraman Reddy meant is
inspection.
No.
Inspection.
Exploration
of the skull base.
Exploration of entire skull base.
Turbinate flap. So the concept is this middle turbinate flap contains the periosteum. When this contains the periosteum, it forms a very, very strong support for the healing process.
Agreed. We are talking about the identification of the leak. When the leak is not known, then I think an intracranial approach should be taken. That's what I mean.
That agreed, correct. Undoubtedly.
I differ, sir. In these cases, we have already discussed, if you are going along the middle to the middle turbinate, you will somewhere find a small bulge there.
Yes.
Because these cases would have a small meningocele down there somewhere. And then you can go lateral to the middle turbinate, do the anterior and posterior thyroidectomy, and see for a meningocele there.
Yes.
Even then, if you don't find, you can use fluorescein there. You can lower the head of the patient. You can do the Valsalva and see the leaks there.
All exaggerative procedures along with the fluorescein can be helpful in these cases.
Yes, sir. But I will not subject these cases to intracranial approaches, transcranial approaches.
Yes. Now we'll quickly move on to the graft materials of your choice. Do you feel there are so many graft materials like this? So do you feel any significant advantage with any graft material in your experience, or is it okay? It is a surgical technique which counts rather than the material itself.
Well,
I don't like bone, but other than all are almost equal.
Yeah. Bone for the reason of resorption.
Resorption.
yes.
For a long time. Yeah.
For me, sir,
Yes.
if it is less than 2 mm leak, I can straight away use a Duragen or a Duraform.
Yeah.
It gives a good repair there.
So overall, I think bone as a graft material should be discouraged because of its resorption, and you can use any material like temporalis fascia, mucosa, fascia lata, thigh, then dural substitute of Duragen and vascularized pedicle flaps, then pericordium, pericranium, Huddard flaps, etc. And Hegazy in the year 2000 said graft material doesn't matter.
Doesn't matter.
It's a surgical. It's a surgical.
Yes, he has a large series in which he has proved that.
Yes. Now I think my favorite this thing is a fat which once you acquire is very difficult to shed it off. So my favorite is the thigh fat and fascia. Anyway, so Dr. Pawan sir.
Yes.
So do you have any particular technique of doing a underlay technique or onlay technique or composite technique based on the defect size?
Yeah, you have already classified it very nicely. If it is a less than 2 mm leak, yes, I can even go ahead with the overlay technique or with the Duragen or Durafoam.
Okay.
And that is a sufficient thing for the repair as such.
Yes.
If it is 2 to 5 mm, I'll certainly go ahead with the bath plug technique, using one layer intracranially of facial lata, a small layer.
Okay, we can understand bath plug technique because we have a lot of questions. Bath plug technique is your option if it is a medium size.
5 mm, I use a cartilage inside intracranially, a thin slice cartilage either, or Huddard flaps.
Yeah, very large Huddard. So anybody want to add to this slide or differ?
Only one thing I would like to say.
Yes, Dr. Rai.
In the very small children, pediatric age group below 2 years, I have seen my neurosurgical colleagues to prefer Duragen rather than any allogenic graft. I asked them.
Yes, sir. I agree because lot of neurosurgeons they prefer Duragen.
Yeah, they told me to avoid. Even in my cases, they told me
Duragen,
to avoid
pericranial flaps.
Especially very small children. I mean, 2 years or lesser. They don't like to give any sort of natural grafts from the body.
Yes.
I don't know the reason. I asked them, but they I insist on that. So I have been also doing the same thing, following on their footsteps, using Duragen usually for the
After
very
all,
small children.
it is their territory. We have to copy some of them from neurosurgeon. Anyway.
I don't know whether Dr. Meghnad has something to say about this. Any reason for using this Duragen?
Replacement therapy, Duragen. You are replacing the Dura down there.
Yes. Yes.
Yeah. And now, your post-op protocol, sir? Dr. Meghnad?
I will give acetazolamide 250 milligrams.
Same as medical management? Same as medical management?
Same as medical management, but I'll give a little lesser dose, and I will not give more than 10 days because the pharmacology says that its action will not be there after 10 days, or rather it will come down very. And IV antibiotics, anti-meningitic dose for 2 weeks.
2 weeks IV antibiotics.
Yes.
Third generation cephalosporins?
Yes. Yes.
Or any other thing? Okay.
Yeah. I use ceftriaxone and amikacin.
Yes. We'll go for
7 days, ceftriaxone for 14 days.
Yes. Babu?
Sir,
Minimize cheddam.
I give a IV for 7 days. Then I switch over to oral good third generation cephalosporin like ciprofloxacin Axetil, 500 milligram twice a day for 2 weeks.
Yes, sir. Agreed. Sir, this is Dr. Pawan.
Yeah.
Yes, sir. Just watch this video. There is a small meningoencephalocele.
We don't see a video there, sir.
No, you'll get it.
Okay.
Venkat, we are not getting the video.
Share.
We'll get.
There are only 8 participants. It's showing down there.
No, that is our group.
Okay.
That is our group, not the.
Starting. Can you see now?
Yeah.
Yeah, we are getting.
Yeah. See, there is a small meningoencephalocele here, very small, tiny, in the upper part of the cribriform.
Yes, sir.
Now, see here, it is a video from Ma. You are cutting the middle turbinate in the beginning.
Yes.
So, I just want to know your way of repairing this particular case.
In this particular case.
Yes.
Yes, sir. So this is a very small meningocele. I think it is up to 2 mm, or it is larger one after that.
4 point.
So if it is a larger than 2 mm, my approach would be the same. I'll use a bath pack technique.
Mm-hmm.
And
so one thing I want to interrupt you. Do you excise the middle turbinate, or you preserve the middle turbinate in this case?
Sir, I would preserve the middle turbinate.
Anybody want to differ?
It itself makes a plug.
Okay. Anybody want to differ, sir?
I would like to exercise.
You would like to exercise? Yeah. Can you support yourself? Why you want to exercise?
Because I can do a good repair under good vision.
But the middle turbinate will offer some, protection-like thing.
Yes, sir.
Will form a tight seal.
Secondary lock.
Secondary lock.
Yes.
Things like that. Some people, they differ.
Yeah.
This is a controversial thing.
Yeah. See, for the successful repair, the most important thing is to ablate the mucosa around the leak. At least 15 millimeter or around the leak. In the presence of middle turbinate, in the narrow crevice, ablating the mucosa is sometimes difficult, and you may leave little mucosa, and if you repair, then there is a risk of a small mucosal formation and intracranial communication. All these things we have seen happening in others' hands, so I don't want to do that.
I comment there, sir.
Yes.
To overcome this problem, I have started using coagulator there, sir.
Yes. Coagulator is 5 millimeter, 10 millimeter.
Inferior turbinate coagulator.
Okay.
Inferior turbinate coagulator can be carved accordingly, and they can be pushed in the cleft between the middle turbinate and the septum easily.
Okay.
And then you can remove all the mucosa with the help of the coagulator down there.
So
Second thing, what you could do is, sir, you make a flap, posteriorly based flap on the middle side of the middle turbinate, elevate it prior.
Yes. Yeah.
And
that can be done.
On the defect.
Next, Dr. Roy, can you look at this slide?
Yeah, I can see.
Yeah, this is a meningoencephalocele on the left side. with a huge meningoencephalocele going up to the almost to the anteriorly, and the defect is only 7 millimeters at the top. So how are you going to repair?
I would go to intranasally paraseptal, and as Dr. Meghnad told, I would also like to resect a part of the middle tablet.
So it's a multi-layered repair?
And it will be multi-layered repair, but here I will use a cartilage. I would like to use a cartilage.
You would like to use a
probably from the nasal septum, or maybe concha would be a better piece, I think, rather than touching the septum. I would take it from there. Or I may use a part of the excised middle tablet and the
wonderful, sir.
Middle tablet for second layer.
Wonderful, sir. Wonderful. Anybody want to differ? No.
Yes, sir. Cartilage with adult flap.
Okay. Adult you want to use, I think you can do a multi-layer repair as well.
Yes, sir.
Multi-layered is okay.
7 mm you told us, sir.
Here, down here the post-op, post-op result after 2 years, you can see almost a normal CT. This is a multi-layer repair, once cartilage, conchal cartilage, and then the fascia and the surgicel. Sir, this is a, Dr. Meghnad, this is a posterior table defect. It's a case of extensive fungal sinusitis or frontal allergic fungal rhinosinusitis with a defect posteriorly, and the patient is getting intermittent CSF leak.
Yes.
So after removal of disease, so how are you going to repair this particular posterior table defect?
This defect, I will do a modified Lothrops, and probably I will get enough space, working space, and I will be able to repair that. If that is not feasible, then I make a small incision in the eyebrow, and make a small trephine, and I can do use the instruments through the trephine, and this all sometimes people call it as a combined.
A bimanual technique like that.
Yeah, like that. Yes. With that one case, I did like that.
Anybody want to have a different kind of opinion?
I would like to add on, Dr. Meghnad.
Yes, sir.
If I have a problem with the trephination, we have an oculoplastic surgeon with us also. We would also go for a pre-caruncular approach medially.
Okay.
To add on, so that they can have a lateral access to the posterior wall of the sinus, which is a big problem. We can add to that.
Yes, sir.
And there's a third way also. I can take the help of a neurosurgeon to add on with a bifrontal keratotomy if I am not successful this way.
Yes, sir. So you should not hesitate going for.
In a case like this,
yes,
when there is a fungal sinusitis, craniotomy should be the last option because of fear of.
Yes.
So try all intranasal measures with some trephination or through some
no, Venkataraw, before that I would like to take an open approach.
External ethmoidectomy. That is a good solution.
That
is better than bifrontal.
Bifrontal. Yes.
But bifrontal is last. Bifrontal last because it's associated with a lot of morbidity.
I can recollect a few cases in my post-graduation period because of some political issues. Few cases were done by the neurosurgeons, and unfortunately, I've seen 4 patients taking rebirth.
Okay, I think this is very answered. That is, try intranasal measures, and if they
avoid
fail,
intracranial.
and avoid intracranial. Intracranial should be the last option.
In such cases, one point only.
Yes,
this
sir.
fungus itself is giving you much of the space down there.
Yes.
This happens.
Yes.
So you have got so much space down there, you can very well repair it intranasally by the endoscopic approach itself.
But this is the posterior table defect is one of the most difficult areas to do a repair.
Modified Lothrops, as Dr. Meghnad said, you can very well repair it now.
In one case, my
failure rate in this case, intranasal attempts, the failure rate is little bit higher in this case.
Yes. No, sir, it is not higher as compared to transcranial for such defects.
A small incision in the eyebrow, and make it refine, and go. I mean, you will have a wonderful, comfortable zone to operate.
Yes, sir. No doubt.
Now, move on to next question, sir. So this is a leak in the Sternberg's canal, the lateral wall of the sphenoid. Dr. Singhal.
Yes, sir.
Yes, sir. What is your approach?
Sir, I would always go ahead in such cases of lateral sphenoidal with the transpterygoid approach.
Yes. But any special precaution you take sealing such, any special precaution you execute in sealing such leaks?
In such leaks, sir?
Yes.
Such leaks, because if I go through the ostia, I don't have that access to the lateral wall.
Yes.
Actually, sir, there is...
No, transpterygoid is done.
Yes,
But for leaking, the technique, surgical technique. So can you tell what important precaution you take for surgical technique? Because these are again, if you don't leak, you seal it properly, the recurrence is a possibility.
Possibility, because there are a lot of arachnoid granulations along
Yes.
with the lateral wall.
Dr. Megnath, you want to add something?
Yeah.
Keep on pushing it. So you have to do by underlay as well as overlay technique in these cases.
Underlay and overlay, both techniques.
Both
Dr.
the
Megnath, you want to add?
Yes, I would like to add here. One technique is transpterygoid. The other method is opening the opposite sphenoid and posterior septectomy. You will have a wide opening to the sphenoid. From the other side, using a 70-degree scope, you can use all the frontal sinus instruments, and you can repair.
So don't hesitate even to go, binostril and forehand technique.
Yes, and you can do a good job. But as Pawan said, we must use a perichondrium.
Yes, sir.
Cartilage
Sir,
graft.
sir, I would like to make a small point here.
Yes.
We always tell cartilage. No, sir. I would like to highlight more than the cartilage. It is the perichondrium which is important, and the perichondrium is a type 4 collagen fiber, and its life is some decades.
More. 30 years, more than 30 years.
More than 30 years.
Next, I think this is my case. There is a child of 11 months, 8 kg, and she has a huge encephalocele extending up to vestibule. And then it is increasing on cry. And then there is an active CSF leak. Dr. Roy, how are you going to proceed with this case?
This case, I think I would need the help of the neurosurgeon. The leak is quite big.
No.
I try to attempt nasally. I like to go intranasally and try to seal the defect.
Yes.
And in the same way as we did in the first case. But the space may be a constraint because it's quite a big mass and the child is small. With a 4 mm scope, even with a 2.7 scope, my access may be having some difficulty.
Dr. Megnath is raised in hand.
Like a small child, 11 months, it looks that nose is small. How do I do? You'll have all the inhibitions and
all, sir, 2.7 mm scope.
You realize
with all the micro ear surgical instruments.
You can use all adult instruments. The nose is very widely widened by the meningocele itself. So you will be able to do the surgery very comfortably.
Sir,
more comfortably than adult because the length is very short.
I think, sir, but this is an easier case rather than other cases for me.
Yes. This will be more easier than other cases.
I'll just follow the meningoencephalocele, go up there, cauterize with the bipolar down there, take out the seal after cauterizing and repair the defect. No hang-ups are there. And I have done such a few cases in even less than 1 year.
This case was repaired almost 7 years back. The child is going to school now. And here I harvested the conchal cartilage and then thigh fat and fascia. You can see I used the 2.7 mm scope and sometimes 3 mm scope with all micro ear surgical instruments only.
Yes.
All steps. And here you can see the first layer I used a piece of Surgicel, and over this cartilage is kept. And then, this is a defect. The meningoencephalocele was so big and extending into vestibule. Ultimately, the defect is about 1 centimeter only. And this is a cartilage seal. And then this is a fat. And over that, I put the thigh fat. And the seal is, and the only problem I encountered in this case is the child was crying, very difficult to keep post-op period. And there is a raised intracranial pressure all the time. But still, he came out successfully in this and the child is going to school. Now, this is
a single question there, sir. Can I ask a question there?
Yes.
Do you always prefer taking a conchal cartilage than the septal cartilage which is available down there?
Yeah, septal cartilage is also good, but here the conchal cartilage in a child is easy to harvest than septal cartilage, because septal cartilage, if you take little more, probably it will prevent the growth. The growth prevention, facial growth prevention is a problem. So that's why I preferred a conchal cartilage in this particular case. And conchal cartilage is a beautiful, it's a cup-like thing.
It is more malleable.
More malleable. Is more malleable. Septal cartilage is thicker.
Yes. The conchal cartilage easy. Preservation of the perichondrium of the conchal cartilage easy. Yes. And you can put it like a button.
Yes. Next, sir. This is a traumatic CSF leak. She had a hit with an iron rod, victim of a husband. And then Dr. Pavan.
Yes, sir.
How are you going to repair, sir?
Sir, this defect is going later to the paramedian of the pupil.
Yeah, you can see the outer table, inner table, both are gone.
Yes, sir, I can see. So this is going lateral to the paramedian of the orbit.
Yes.
Lateral to the median of the pupil. In these cases,
lateral to the mid-pupillary line.
Yes, sir. So I won't venture for the endoscopic approaches in these cases. So I think
yes, sir. All the panelists agree? Okay, sir. All the panelists agree with this?
Only option is the external approach.
External approach. So yes, this is what bifrontal approach. This is a bifrontal craniotomy was done with the pericranium, and the defect is sealed. And now, this is a frontal meningoencephalocele, a 7 days old child with a mass lesion in the nose, which was bleeding occasionally, and it is coming out through the foramen cecum. And then I straight away go to Dr. Roy to tell about this case, how he has tackled.
The problem with this child at presentation was that she was having fever and episodes of convulsions just after birth. And there was blood stain discharge from the nose, and just on touching also it was bleeding. My problem was that this was bleeding. On touch it was bleeding. So I was not very confident that in that child with a small scope, in bleeding I would be able to tackle it. So we went for the combined approach. My neurosurgeon friend helped me with the bifrontal craniotomy from above, and I went from below.
Oh, you have done your job.
We tackled the case.
I think these are the cases which require a combined approach.
Hello.
This is the case which required a combined approach,
yes,
sir.
I had to opt for it.
Yeah.
Yes, I couldn't
and
manage
intranasal part. Yeah, you have tackled the intranasal part and you have sealed from top.
Yes. I had to take the help. So
very nice.
There.
Yeah.
It was a huge mass, and it was a 7-day-old child. Yeah. I couldn't venture alone with this 7-day-old child with active. We did it together.
Now,
Dr. Meghnad, would you differ on this? Would you have
absolutely same? No issue. No issue in that.
You would have taken the.
Yes, I think I would have done the same thing.
This is an earlier case. This is a case which require only external approach.
I was right.
Dr. Roy, we are not getting your audio. Okay. May I suggest you to stop the video so that we'll get your audio.
Thank you.
Dr. Roy?
Dr. Roy, you stop your video and speak only.
Yeah.
Stop your
now
video,
you're audible.
Because signal is very weak on your side.
You can hear me?
Yeah.
Yeah, I heard Dr. Meghnad say that you would have also have taken the same approach.
Yeah. I think this is a case which require only external approach, and this is a combined approach.
Okay.
Combined approach, yes.
Yeah.
Yes, combined approach. Agree.
Yes.
Agree. Okay.
Now, sir, what are the complications of endoscopic endonasal repair of CSF leak? Anybody encountered any complication significant?
Sir, the most dreaded is the re-leak.
Yeah.
That is
recurrence.
Recurrence.
Recurrence, of course, recurrence is a position, it's not a complication.
Yeah.
But do you have any hemorrhage, hemocephalus, anosmia, headache, meningitis?
I have seen in 2 cases, sir.
Yeah.
Pneumocephalus I have seen, but they were conservatively managed. As neurosurgeon said that it will be absorbed on its own, so don't have to worry about that.
Dr. Roy, did you encounter any complications, sir?
Not related to the intracranial complications. I lost a patient because of pulmonary embolism.
Okay.
I lost the patient on the third day because of pulmonary embolism. She was a bit obese, and we didn't put any pressure stockings. We had not put that, and ultimately she died because of pulmonary embolism. That is the only thing which I had faced till now, and not related with the leak repair or anything.
Dr. Megnath, any complication in your experience?
Yeah, not happened in my hand, but I received a patient who has been operated, repaired, and after that the patient has developed hemocephalus. So again, we have not done anything. With the help of the neurosurgeon, we have done conservative management.
I think most of the complications except hemorrhage, all complications are to be approached by neurosurgeon, and he is the person who has to get involved in most of our complications, except probably nasal hemorrhage, which we'll take care of.
Yes.
And now, I think this, in addition to the mid-pupillary line approaches and all those things, so straight away open approach, when what are the cases where you go for only open approach? So cannot do endoscopically.
Multiple leaks, in case of multiple leaks.
Can I?
Yeah.
In case,
yes,
in case of multiple leaks. In case of multiple leaks, we'll go for a open approach.
Multiple fractures, I would rather say, of the cibriform plate or the lateral lamina, cibriform plate, or maybe
any far lateral lesions. Far lateral lesions
that we have already discussed.
Yeah.
Yes, a posterior table far lateral lesion. Yes, yes.
Yeah. Now the recurrence rate, because our success rate is almost close to 90 or 95%, sometimes even 98%, but any recurrence, significant recurrence rate?
Yes, sir. There are around 12 cases I had to redo.
Mm-hmm.
Out of my 130 cases, 12 cases I had to redo, and a few cases lost to follow.
Sir, what are the causes of those recurrence? Is it due to multiple leaks, or non-identification, or a wrong site you have done it, or a CSF photoria, or a faulty surgical technique, or is it associated with benign intracranial hypertension?
Yes, sir. There were 2 cases in which fat ladies were there, so they were cases of benign intracranial. In one case, I missed the contralateral side. It was from the crista galli leak.
Okay.
I repaired on one side, and I could not find the defect on imaging on the other side, because the patient was just complaining on this side, and it is coming. But later on, the patient was developed a leak on the other side.
Okay.
So that was a difficult scenario. I had to sacrifice a part of the upper septum. I had to repair there. So then it was like such a case, an interesting case.
So did you encounter any benign intracranial hypertension? Any case?
Yes,
as a cause of recurrence?
There are 2 cases I've seen.
Then what did you do? Do you go for shunts?
I sent the case to ophthalmologist to see the retina, the papilledema, and it was there. I consulted the neurologist, then I sent the reference. Then they started the continuity treatment for BIH.
Oh, if you find optic nerve atrophy and empty cella, you take the opinion of a neurosurgeon and go for shunt operations?
Yes, sir. These cases which are not improving should be subjected to shunt operations, and neurosurgeon can be given a reference.
Okay.
Yes.
I think we are well within the time. Maybe we have exceeded 5 minutes. And thank you very much for the panel. I thank all the panelists. I think they are within the time. We are a little bit faster, but to cover all the aspects of CSF rhinorrhea.
Yes, sir.
And now I request Dr. Megnath to go for his presentation, and later on we'll switch over to question and answer session.
Yes, sir.
Dr. Megnath, should I click on stop?
I think they have to permit me to do the sharing the...
Yeah, should I press on stop sharing?
Yeah, you stop it, then I can do it. I'll be giving the presentation of few slides on the allergy.
Yes.
Yeah, are you getting this?
Yes, yes.
Yeah.
Yes.
we know very well that around 30% of the world population suffers from allergy. Maybe in the rural area it is less because diesel exhaust emission products are more in the urban area and they increase the allergy. And is the fifth leading chronic disease among all ages, third common chronic disease among the children under 18 years. That means almost 1 out of 3 are affected by the allergy. The environmental factors increase the impact of allergic disease, like air pollution. All of us have experienced very, very low allergy during the lockdown because the DEP, the diesel exhaust emission product, are reduced because of the decrease in the vehicular traffic.
Thanks to Corona.
Thanks to Corona. And we understood what we are doing wrong. Yeah. And of course, the tobacco smoke is very bad. And early life viral infections, certain drugs and stress, all these increase the allergic rhinitis. And some food sources, access to healthy and adequate food sources may influence the asthma through the malnutrition or obesity, as both are linked to the asthma and allergy. And if you look at the hospital admissions, new onset asthma complications, all are secondary to the allergy and allergic rhinitis. They are significantly contribute to the morbidity of the society. And we know very well that atopic march starts from the food allergy and then goes to atopic eczema, dermatitis, allergic rhinitis, and finally asthma. The WHO slogan today is to stop the allergic march or atopic march by giving antihistamines, especially the oral antihistamines and intranasal corticosteroids for the children who are having allergic rhinitis. So let us, we have to identify that allergic rhinitis and understand that it is two types. We know very well that acute allergy, all of us will identify the chronic allergy, which we are likely to miss. Here, coming to our present topic, and sorry. Yeah. So the allergic rhinitis, common cold and CSF leak. Sometimes these are confusing, but if you look at the CSF leak, the fluid leak is gush cannot be controlled by the patient. And all of you agree?
Yes.
Yeah. And this fluid from the CSF rhinorrhea is not associated with any provocative factors like dust. And usually they create the flow of the fluid, and the fluid comes drop by drop and the patient can feel it. This is a typical history in a CSF rhinorrhea, whereas when it comes to the allergic rhinitis, it comes out, the discharge is clear and it starts suddenly along with sneezes. In case of common cold, it can be thick or colored in the latter part of the common cold. Usually in CSF rhinorrhea, the fever is absent, whereas in common cold, usually we see the fever, and again in allergic rhinitis, we don't see the fever. And of course, we know very well about the handkerchief or tissue test. And some patients can feel the constant flow of liquid postnasally into the throat, and these features identify the differentiate from the allergic rhinitis and common cold. Yeah. If you look at this slide, I would like to highlight, this is the persistent mild varieties of allergic rhinitis, what we are likely to miss. If you are aware of it, then you will be able to identify them and give the anti-allergic treatment. Intermittent, we definitely identify a severe, acute, or severe intermittent. We always identify them. What we always miss is mild and persistent allergic rhinitis, chronic allergic rhinitis, or we are likely to miss. So we have to be careful and keep it in our mind. Of course, we very well know that pollutants are very significant contributing factor in all over the world, and the allergens they are proteins or glycoproteins or glycans. They induce and react with the specific IgE antibodies. They originate from a wide range of animals, insects, plants, fungi. These allergens include inhalant allergens. House dust mite is very common, and in our practice, I see 60% of my patients having house dust mite allergy, and because I work in, I'm working in the city, and most of my patients have the dust mite allergy. Around 30% have the pollen, the 10% the other allergens. And we know the symptoms of the early symptoms are sneezing, rhinorrhea, itchy nose, and red and watery eyes. All of us know. I would like to highlight the late symptoms like pain and pressure in the ears, nasal congestion, sore throat, cough, and headache, blocked ears, postnasal drip. These are seen in the chronic allergy, and we should identify. If we are aware of these things, then only we will be able to identify the chronic allergy. My talk, I've asked the Bayer people to give me 10 minutes time to talk about the chronic allergy, which we are likely to miss these conditions. And with antihistamines, they do wonderfully well. Of course, this is the allergic shiners, allergic conjunctivitis, the salute crease. And if you look for the salute crease in chronic pharyngitis patients, you will identify that, and that will help you in diagnosing the chronic allergy. And 40 to 50% of patients with allergic rhinitis will have asthma, and around 30 to 80% of the asthmatic patients will have allergic rhinitis. We have done a study in our hospital looking at the fungal rhinosinusitis. 80% of the fungal rhinosinusitis patients are having asthma, and 70% of the asthma patients are having fungal sinusitis. And one of the tests what we should do is the skin prick test, and which we do routinely in our hospital, and estimation of IgE is also very important. And another important thing what we do routinely in our hospital is the nasal smear for eosinophils, for the counting of eosinophils in the smear. More than 5 per high power field, it is significant. And coming to the management, we know about the immunotherapy, subcutaneous and sublingual. Unfortunately, we don't have any experience about these things because it's not FDA approved as of now in India. We have only for the, we have FDA approved skit only for the house dust mite. But the most important thing is the saline rinses, they reduce the chemicals, the chemical mediators in the nose, and they improve the symptomatic well-being, and also the complication rate is reduced by using the saline rinses. So I rely more on the saline rinses, and of course we know that in tough cases, in stubborn cases, I prefer omalizumab, which is an injectable form, and you have to give it once in a month. It's a bit expensive, but still it is very useful in stubborn cases. And in still stubborn cases, if the patient can't afford, we give AST, anti-serum therapy. So anti-serum therapy is nothing but we take 10 ml of blood from the patient, we prepare the serum of the same patient, the same individual, and that is injected into the intramuscular injection into the gluteal region. This is to be repeated once in a week for 4 weeks, and then once in a month for 4 months. This also gives very good result. It acts something like anti-IgE. This is called AST, anti-serum therapy. And oral antihistamines are the first line of treatment, and the next one is the intranasal corticosteroids. But as per the area guidelines, the first generation H1 antihistamines should not be used, and second generation like cetirizine, levocetirizine, loratadine, fexofenadine, desloratadine, and these are better tolerated with fewer side effects and very few anticholinergic effects. And there is no requirement of any dosage adjustment for the renal or hepatic impairment. The first generation will have longer plasma half-life compared to the duration of action. The second generation, the duration of action exceeds the plasma elimination half-life because the end products do also have the antihistaminic action. If you look at this table, you will understand that oral antihistamines are good in controlling the rhinorrhea, sneezing, and itching. For the nose block, the nasal steroids are good. Nasal decongestants are good. And for the eye symptoms, nasal steroids also work along with the antihistamines. The duration of onset of action is around 1 hour for oral antihistamines, whereas the nasal antihistamines is only 15 minutes. Nasal decongestant work very fast, but the intranasal corticosteroid, please remember, they work very late. And the duration of action with oral antihistamines is about 24 hours, and with nasal steroids is around 48 hours. So that's how the antihistamines working on the blocking the histamine receptors. So here, coming to the loratadine, I would like to highlight that carboethoxyloratadine is the active compound. Even though the loratadine half-life is only 8 to 11 hours, the active metabolite has a half-life beyond 24 hours, and so it makes it possible to give once-a-day dosing. And single and multiple doses of loratadine suppress the wheel response to intradermal histamine within 1 to 2 hours of oral administration, and that shows that it is a very efficacious molecule. So a detailed history is useful in helping to distinguish between allergic rhinitis, CSF leak, and other forms of allergic rhinitis. And one thing we have to understand is not only the eosinophils, even the polymorphs also, basophils also are responsible for in some cases, for the allergic rhinitis.
Hello.
Thank you. And I think we can go for the questions. I'll go to the questions. Yes. Yes, Venkatram?
Hello.
Yes.
Am I audible?
Yes, Venkatram.
My laptop has hanged up for some time.
Okay.
Now, thank you, Dr. Meghnad, for such a brief presentation and very nice presentation. And we'll go for question answers. You have questions with you?
Yeah, I have the questions with me. What are the lab tests? Dr. Neha is asking, what are the lab tests should be done other than sugar and beta-2 transferrin in the fluid to differentiate between the CSF, rhinorrhea, and nasal discharge? Anybody would like to answer this? So I think it's the beta trace protein is another test what we can do, and beyond that I don't see any other lab tests to identify the nasal discharge. Beta trace protein, so it is more reliable than the transferrin, and I think CT cystoscopy already we discussed, that is more reliable. Sorry.
More questions? Any more questions, sir?
Yeah, there are questions. Just a minute. There is some problem. Yeah, I got it.
Okay.
Just a minute. Yeah. How to rule out benign intracranial hypertension without CT cystoscopy?
Benign intracranial hypertension on CT cystoscopy.
Without CT cystoscopy.
Without CT cystoscopy.
Yeah.
The history itself.
Yeah. You can do the MRI scan. In the MRI scan, you can see the empty sella and dilated ventricles.
Empty sella
Syndrome. Yes. And what I do, I discussed, I check the opening pressure when you do the lumbar puncture for the CT cystoscopy. If it is more than 15 centimeter, that indicates there is benign intracranial hypertension. Fourth one is the fundus examination. But all these things are not very efficient before the surgery. That's why in all my patients, what I explain them is, you have benign intracranial hypertension, which has to be treated after the surgery only, because you can diagnose only after the surgery. All my CSF rhinorrhea patients, I call them after 3 weeks to go to an ophthalmologist, get the fundus checked. Number 2, I will repeat the MRI after 2 months to see whether there is any benign intracranial hypertension. This can be diagnosed on the MRI scan.
Sir, on MR, one more finding is there. There is increase in the diameter of the optic canal.
Yes. That you can see even on the CT system.
That is very important finding. As such, it is earliest finding what a few literature say.
Yes, absolutely. So
you have to compare.
One is the diameter. Number 2, extension of the CSF space of around the optic nerve extends up to the globe.
Up to the globe, yes, sir.
Up to the globe, up to the eyeball.
Even beyond up to the annulus of Jin, where all the things are going and inserting, up to there it goes.
Yes.
So it is one more finding there in an MR.
Yes.
And patient also presents with a chronic diffuse type of headache.
Yes. See, the only problem is, as long as the leak is there, the false negative
headache is minimal.
Headache is improved.
False negative is
to
high.
Close the leak, I think.
So always you do the closure and say bye-bye. No, you have to look for the benign intracranial hypertension for 2 to 3 years. It can present very late also.
So it is vice versa, sir. Benign intracranial hypertension giving rise to increased ICT, giving rise to pains, headaches.
Yes.
And sometimes due to the leak, the low pressure is there, which also gives a type of headache.
Yes.
So both the things might be very tough to differentiate.
Yeah, but also there are occasions where there is raised intracranial pressure, but after the CSF leak repair, because of some changes in the dynamics of the CSF circulation, the hypertension becomes normal.
Yes.
That is also possible.
That is there. Yeah, some reflexes are there.
Yeah. So even if you see the benign intracranial hypertension, repair of the CSF leak is equally important.
Yes.
Dr. Ranbir, does MRI contrast help? This is to identify the tumors. Am I right?
Yeah.
I don't think it has any role beyond that.
Yes, to rule out the other lesions.
Malignancies.
Other intracranial lesions.
In case of intermittent CSF leak, can IGS will help?
Pardon?
No.
IGS?
Image guided system. No. We don't gain any advantage.
No, if you are lost during endoscopic sinus surgery, if you are lost, then the IGS can help you to take a suspected area of CSF.
Yeah.
If the CSF is leaking, not actively there, and you can identify with the IGS and graft that a particular area, irrespective of not visualizing even the CSF.
Yeah.
But sir, in a few conditions like lateral recessed leak of sphenoid, you can use image guided system.
Yes.
Because there are vital structures out there.
Yeah.
And for
wherever in CSF leak, wherever you are lost or not able to identify intraoperatively, the IGS will definitely have a bigger role.
Yeah. Yeah, it doesn't help particularly in intermittent CSF leak, but I would like to use the IGS in all CSF leak. One more way of confirming the leak demonstrated in the CT cystoscopy, whether it is correlating. So because there is a chance of multiple leaks, that's why I always use the IGS to identify any second leak, whether I'm missing the first leak. Dr. Ranbir again is asked, what about the fluorescein stain? I think we had a long discussion about that. He raised that question before the discussion.
Yes. I think all are cleared.
Yeah. Somebody commented, best is the vascularized graft with fat. Yes, best is the vascularized graft, but for a small leak, taking a vascularized graft is not
feasible, not feasible.
And also it increases the morbidity.
Yes, sir.
Vascularized graft means if you take a Haddad for a small leak, and
it's an overkill.
Yeah, overkilling. And also the risk of anosmia.
Yes.
After the adult flap, some patients go into anosmia, which you can't.
Anosmia, and sir, a lot of
crusting, anosmia, all those things.
Crusting.
Killing takes a long time.
Donor site morbidity is higher.
Morbidity is very high. Very high.
No doubt.
And I have done few Haddad flap. I have to take care of the patient for nearly almost 3 to 6 months. We have to take care of the nasal cavity.
Like it is justified for a large skull-based defect, or maybe a large pituitary, you can use it. For tumors, you can use it. But not in every case of CSF leak. Yeah. You have to weigh the things, what benefits and what are the harms.
Yeah. Dr. Vinod, what is Duragen?
Artificial dura. It is artificial dura.
It is synthetic dura.
Synthetic dura.
How it is available? How much it costs? Any information?
No,
it is available. The cost is around 5,000 to 6,000, and it is available.
Yeah.
Readily available. I think Johnson's & Johnson's, they make it.
Yeah. Do you use absorbable plates? No.
Absorbable
Anybody uses absorbable plates are also available. Synthetic plates.
Synthetic plate? No.
Yeah. Dr. Amit Keshri, the Stenberg canal nomenclature is no longer there.
Yes.
Yeah.
He is right, sir.
He's right.
I wanted to make a comment over that.
Yes.
There is no entity like Stenberg's canal as an etiology for the lateral sphenoidal recess. As I told you, there are a lot of arachnoid granulations in the lateral wall of sphenoid, which keep on giving pulsations and erodes and thins out the bone down there.
Yes.
That gives rise to a defect down there, and the dura herniates in the sphenoid.
Yes.
Yes, true.
So it is no longer there. It was a theory given, I think, far back in 1960s or something like that.
Yes.
But
agreed. That's agreed. Still, the great man has described it in remembrance as a gratitude towards him.
There is a good account of publication in his name, because I think he has done quite a few more things. I have gone through that.
Yeah. So, indication for surgery in spontaneous CSF leak in elderly people.
Incidence of?
Indication for surgery in spontaneous CSF leak in elderly people.
We have to see each and every leak. Each and every leak has to be seen.
Yes.
Because of osteoporotic bones.
Yes.
Yes.
One factor is that.
Yes.
The second is, usually with the age, raised intracranial pressure is there with small movements and bowel and all those troubles are there. And the chances of meningitis are
very high
in elderly as compared to the adolescent or the pediatric population.
It has to be closed.
Yeah. What is the role, Dr. Saket? What is the role of anti-epileptics in post-op management of CSF repair? Should it be employed in all the patients?
Not in all.
Not in all, sir.
Not in all.
Give it. If it is a large and if then I get a reference from the neurosurgeon and neurologist they suggest the dosing.
So the neurosurgeons, yeah.
Neurologist, I don't start it on my own. If it is a large brain herniating in that seat, then.
So I put it like this: if you have manipulated the cerebral cortex,
yes,
then you must use
anticonvulsants.
Otherwise, that is the beauty of endoscopic repair. You don't have to.
That's why neurosurgeons have a regular prescription of this in each and every case of
like we give antihistamine.
Yes.
That's what.
That is for decreasing the CSF production, as you told. Dr. Venkat told. Decreasing the CSF
production. And also it works as anti-epileptic. Anti-epileptic also.
No. Any other questions and important questions?
Yeah. The next question is again Amit Kashri. I couldn't understand his question. I request Dr. Amit Kashri to rewrite the question. Nasal ala collapse also happens. I didn't understand what is that. Okay. He made a comment that we need CT to see the bony defect. Yes, we all agree. That's why CT is the gold standard of investigation for CSF rhinorrhea, HRCT PNS, and CT cystoscopy is the confirmatory for the CSF.
Yes.
Yeah.
He's right. That's what we have discussed.
Agreed. Dr. Kantilal, pranayama with Vilom Anulom therapy works very well in allergic rhinitis. What is your experience? Yeah. Yes, Dr. Kantilal, I will try that and I will get back to you in the next COVID session. How long
second wave?
Second bout of COVID-19.
Yeah.
Second wave.
Second wave. How long you would advise steroids to be given to the allergic rhinitis patients? Anybody would like to answer this? Dr. Kantilal.
The intranasal or oral? What does he want to know?
Probably
oral or intranasal.
Probably intranasal.
Intranasal is always 2 to 3 months. You can give at a stretch and then give a drug holiday. At least 3 to 3 months. Give a small drug holiday if it is a seasonal type of allergy, and then resume it. Then resume it again.
Yeah. Yes. What I do is I take the history, whether it is a seasonal or a perennial. If it is seasonal, I will start at least 2 weeks or 4 weeks before the season starts, because it is not very dogmatic that it will start only in the month of May 15th. No, if he says he starts it, he gets the problem from May 15th, I will start from April 15th, at least 4 weeks before the season starts for that patient.
Sir, I have got my management according to me. It is not maybe the evidence-based medicine what I am following, but these cases which require longer duration INCS, I give them for 2 to 3 months. Then if you abrupt them spontaneously, there are recurrences of symptoms. So what I do is I give them 5 days a week, then give 2 days off so that no drying or things is there and he's not getting that. Or sometimes what I do is today I'm giving him antihistaminic, tomorrow I'm giving him INCS, day after tomorrow I only antihistaminic.
Alternate therapy.
So this is how I have developed in my practice, getting good results, not published yet, maybe not according to EBMs, but I don't always go ahead with the EBMs.
Yeah. Okay.
Next question.
Dr. Ramachandran complimented Dr. Venkatram Reddy as an excellent presentation and all the panelists. Sir, can you please repeat anti-serum therapy? Dr. Santosh from Pune. Yeah, anti-serum therapy is very simple. Take 10 ml of blood, draw blood from the vein and centrifuge and prepare the serum in a sterile test tube. And you have to centrifuge it for about 20 minutes. The serum will come on the top of the upper layer. You will get around 4 ml of serum. Take 2 ml of serum and inject intramuscularly. It's very simple. You repeat every week for 4 weeks, then once in a month. Very stubborn cases, they respond very well. We have done in about 20 patients. And the literature says only 20% do improve with the AST, but in the selected patients, we have used it in 20 patients, and fortunately, all of them have improved. I employ this AST when patient doesn't respond to the antihistamines, when patient doesn't respond to the intranasal corticosteroids. In that situation, I'll use this if I can't afford the omalizumab, because this is absolutely zero cost. Dr. Kiran Kumar, he complimented all of us, a wonderful academic feast. Do you prefer cartilage and perichondrium together or? Dr. Ramachandran. Yes. Can I answer this? Yeah.
Yes.
I prefer cartilage and perichondrium together. Here, I use the cartilage to maneuver the perichondrium. Here, what is that I'm using is the perichondrium, not the cartilage. I get the benefit from the perichondrium because perichondrium and the periosteum, they are type 4 collagens. Their life is 30 years and they will not disappear from there. Even after 30 years, if you open and see, it will be there. If the cartilage will disappear.
No, the perichondrium itself is very, very thick graft and you can manipulate very easily.
Sir, if the cartilage is there, manipulation is easy.
Yeah.
Easier.
Yeah, with cartilage, of course.
See, without cartilage, it rolls over and it becomes very difficult to spread it.
Spread it out.
That's the reason I keep the cartilage. In
So
fact, what I'm using is the perichondrium, not the cartilage.
So the perichondrium side should be facing down, outwards, and the cartilage should be facing inside.
Yes.
So that this perichondrium will also give rise to fibroblastic reaction with the undersurface of the intracranial cavity.
Yes. Yes.
Another thing is the cartilage acts as, a buttonhole type of leaking.
Yes.
I mean, the seal.
Yeah. I have a good number of videos where I follow the same technique, but I think showing videos in a presentation like this will not give the good message because the subject is more important than the video. Okay. Do you prefer, it's over. What are the chances of polyp formation and sinusitis after CSF rhinorrhea, leak repair, and what is its management? And if it is refractory to the medical management? Dr. Baljit Singh.
It's like allergic polyposis. If the patient has got a tendency of allergy, so it is less like he or she can develop that. And you have to deal with it like you deal with the normal allergic polyposis.
Sir, I have an experience of dealing one patient. What I have observed is, I've been observing one patient who has undergone the repair of the skull base with the middle turbinate flap and is a known patient of polyposis. And somewhere else he was undergoing the surgery, iatrogenic CSF leak, I have repaired it. Now, this patient develops the polyps all over the nose except my repaired site. So, if you look into it, they probably the
scraping off
because of fibrosis.
Because of fibrosis, and the eosinophils cannot reach there because there is no vascularity.
Yes,
yeah, that's the reason why the polyps will not form on the site of repair. Observing it whenever
eosinophilic reaction only on the mucosa.
Yes, that site will not form.
The mucosa over the repaired site is non-functional.
Yes. Yeah, how do you manage chronic anosmia? It's very difficult.
Anosmia.
How do you manage? I don't know.
Usually,
I'll send them to a neurologist.
Sir, but usually we are operating on one side, the other side is intact. The other side is intact.
Yeah.
So I think not much that it is hyposmia rather than anosmia in these patients.
What are the role of, where is this, neurosurgeon in recurrent CSF leak? Even in recurrent CSF leak, I would like to try once again endoscopically because of the less morbidity. And if the second surgery also fails, then probably to the neurosurgeon.
We have already defined indications for subjecting these cases for the transcranial approaches.
Yes.
So, in a case of recurrent CSF leak, I think it is, if you have an evidence of the benign intracranial hypertension, probably you have to take the help of neurosurgeon, and you can do a repair, a second repair, and then patient should go immediately for shunts.
Yes. Shunt. TP shunt, thicoperitoneal shunt with a remotely adjustable valve. They'll put a shunt. There will be a valve. They can release the pressure and modify that remotely. It's a bit expensive, but it works well. For cribriform small defects, is post-op nasal pack needed if you don't resect empty? Dr. Ahila Swami. In all, I do keep.
It is better to keep tamponade.
Yeah.
You have to keep in all cases. Because whatever a single layer or multi-layer assembly you make it needs a stability for some time to keep your assembly intact. At least for 5 to 7 days. It is for 5 days.
Rather, I use two pieces of Meroset. One is vertical piece and one is horizontal piece to keep it in place.
Agreed. Yeah. Dr. Arshad Imam, nice presentation, Dr. Meghnad and Venkatram. Thank you very much. Please comment on transfer of nasal mucus from a healthy person to the allergic rhinitis patient. Is there any role of this in the management of allergic rhinitis? I'm not aware. Anybody is aware?
I'm not.
No. Okay. Dr. Rakesh Meena, for spontaneous CSF leakage, will you go to measure the intracranial pressure before repair? Yes, I do as a protocol in all the cases. When we are doing, it's very simple. When the anesthetist is doing the lumbar puncture and injecting the dye, he can, before injecting the dye, he connects it to the manometer. That's all.
Yes.
Manometer is nothing but an IV set connected to the IV stand, and which has saline in it, and see how much is the fluid. It should have a scale. That's enough. Dr. Alexander, very informative session. Thank you very much. What is your experience with immunotherapy? Anybody would like to answer this? Dr. Ramachandran?
Yes, sir.
Yeah, immunotherapy.
Immunotherapy. I do subject cases to immunotherapy also, sir. Or those cases which are resistant allergic rhinitis, very severe, not getting like having history of maybe years, then I subject them for allergy test. And if particular allergens are coming on allergy test, then immunotherapy has got a role here.
Okay, thank you. Do you assess IgG levels in allergic rhinitis as a routine? As a routine, I do IgE, and if that is normal, then I will assess IgG.
And sir, one more thing is there, vitamin D estimation.
Yes.
These days, yes. I have started ordering for vitamin D and IgE, both the things. And TEC, total eosinophilic counts.
Dr. Sakent commented, a wonderful webinar. Thank you, Dr. Sakent, for your comment. Dr. Meghnad, Dr. Ahila Swami, you didn't mention surgery for nasal allergy. Your view on PNN?
Yes.
Yeah, Dr. Ahila, you are an expert in it. I know you do a wonderful job in that. I think we should have one webinar again with you on this topic.
Yes.
Dr. Santosh, please enlighten about your experience on skin prick test and slit. Dr. Santosh from Pune.
I will tell you about slit. I had a small study with sublingual immunotherapy for the age group of children from say around 2 years to around 8 years, 9 years of age. And I studied them for around a year, putting them on slit. They didn't, with another arm with no slit. there was not any obvious difference in the decrease in the morbidity, like sore throat and recurrent cold and all. I didn't find it very helpful. Sublingual immunotherapy, I had tried that. So that is the only thing which I have tried, not the injections and the other things, but I have tried sublingual oral therapy. I'm not very happy. With so many antigens in India, so many tropical antigens, I don't think it has any big role to play in our tropical country. It's my personal view.
Yeah. Dr. Ahila Swami gave an idea. If you suture the septum to the middle turbinate in the post-op, pack is not needed. Yes, that's a good idea. Dr. Ramachandran suggested smell rebooting is a new idea for anosmia, smelling strong smell for few minutes daily for months. But again, he commented results unknown. Dr. Ramachandran does IM therapy. I think probably he's talking about AST, anti-serum therapy, work in patient with multiple allergies. Yes, absolutely. It works in multiple allergies. Okay, Dr. Prateek commented it's a nice presentation, very informative. That's about the very good number of questions. And these questions definitely enlightened all of us. Few questions I couldn't answer. Probably I will go back and read. Anything from the panelists, Dr. Venkatram?
It was excellent.
It was nice. It was nice to be part of this panel.
Very nice
to
to be with all. Yeah, to be with all our colleagues all over India.
Yeah.
Very informative. You have collected
Thank
a very
all
nice
those who have
collection
joined.
of cases. Very nice collection of cases.
You
And very
have made it so nice panel, interesting one, and it was free flowing
Yes, sir.
panel. Thank
Yes,
you
sir.
so much for this space. Yeah,
and we have all learned. We have all learned.
we have learned. Yeah,
Dr. Venkat, Dr. Meghnad, we have all learned.
Thank you very much.
we don't
Thank
have
you.
time for videos now, I think.
Yeah,
Yeah.
thanks. Thanks
So
on
what we
behalf
can do
of.
is, sir, if
Yeah.
they
No,
already-
if you, we do have, Dr. Pawan, we do have a lot of
I think we
videos.
have
I have a lot of
5
videos,
minutes.
but thing is, if you play the video, the quality gets reduced and it takes a lot of time. Lot of time.
True.
Yeah, why don't we try for 5 minutes? Pawan, can you share? I will.
yeah, you want me to play that
Yeah,
Cellular leak?
video.
Yeah, cellular leak video or meningoencephalocele.
Stella, you saw this?
I am leaving the screen sharing.
So there that comes. Okay. So which one do you want me to see the to show the cellular floor leak?
Stella, show this, Stella.
Yeah.
Hello.
So it is an interesting case.
We want Dr. Roy, you also get prepared to show if you want to show anything.
No, mine is already with Dr. Venkat.
Already done. Okay, very good. Good. Right.
Done.
So it was an operated case from the periphery of Jaipur. It was referred to me because there was a re-leak. It was done by a neurosurgeon. Look at the things inside. What he has done is, it was a sphenoidal leak. So he just filled the sphenoid with some fat or some facial lata. Optic now, can you see there? It is optic isotope as you can see up there. And this is something the condition is inside. So what I did,
Dr. Pawan, we are unable to see the video.
yeah, you are not seeing that. Oh,
No, we are not seeing. Are you seeing Venkatram?
No, we are not seeing. We are not seeing.
No, you're not seeing. No.
it's showing me that you are.
I think you have to share the screen again.
Okay, I'll do that. Stop share. Share
No,
the
keep
screen
that
again.
playing. Keep that playing.
Yeah.
And go to the share screen and select that video playing.
New share and select that video playing. Okay.
Yeah, now we have got it.
You got it
Now
now?
you can see.
Yeah, now we got it.
Okay. So this is an operated case which has got, you can see the facial lata putting there on the floor of the sphenoid.
I'm seeing the optic nerve.
Yeah, optic nerve you can see there.
Yes.
And what the previous surgeon has done, he has just clogged the whole sphenoid sinus with fat and something like that, and some fascia. Because he could not reach to the leak, he could not make out where the leak is. So what I started doing is, I raised a dart flap and preserved that dart flap there in the nasopharynx. I put it there in the nasopharynx. Then, as we do in the pituitary, I broke the keel of the sphenoid, and like this, you can see the keel of the sphenoid from the right side of nasal cavity. So I removed this keel so that I was head on the pituitary, the sella, and the clivus. So this is how I'm taking the soft tissues all around the intersphenoidal sinus, and you can see this, the sella there. Am I audible? So
Yes,
this is
yes.
how the pad is there on the floor. The previously operated things. The pad is freely lying there in the floor of the sphenoid sinus, and you can see the pituitary there now. Sella. Okay. So I went ahead, and just like you do pituitary, I expose it from one carotid to other and remove and drill these bones from the sella. And yeah. Can you see under the sella toxica there is some leak? So I saw this leak at the floor of the sella rather than from anywhere. So this made a diagnosis of floor of sella defect. So what I did is how to repair this defect. You can't do it from underlay. You can't go down and you can like remove the floor of the sphenoid sinus, and from down you can repair, but it is not difficult. It is very difficult to do that and not effective. So what I did is, like in all cases pituitary we do, I flattened the bone of the sella, and then I removed the bone from the sella. You will be seeing in the coming picture, like you see this defect there. You remove this small tissue there from there, and you will see the defect. Okay, so I flattened, made the eggshelling of the bone of the sella, and then remove this bone with the use of the chisel. Okay, made further thing. I'm removing this bone. Then after removing this bone, as you do in pituitary, I'm elevating the whole pituitary gland and making some space in the floor. You will see in the yeah. So this is how I'm using the suction Freer elevator, and I'm making some space there at the floor of the sella, so that I can repair the things. So this is how I've made the space. After that, I'll be using a piece of the surgery cell there. Yeah, this is how. Yeah, if it is not going up, you can coagulate a bit of the meninges there. So they will retract up there. Can you see this defect? It's a small meningocele at the floor of the cell, which I am coagulating now. So you have got this space down there. Then you can plug it with a piece of the surgery cell, and then you can fill the defect with fat, and later on this can be further reinforced with the help of, I'm sorry, it is with the help of the adult flap you have raised. So this is how the final picture was, and then I'm using a piece of surgery cell over this adult flap, and the packing is being done. Was it clearly seen?
Yeah.
Yes. Little bit, break.
Pause.
Yeah. There's a bit
The video
of pause.
quality might not be that good because
Because
I
of
work
internet
in the government
issues.
institute, so we don't have spice or something like that.
Yeah, that's wonderful.
Thank you.
That's nice.
I think we can we take it a day? Call it a day?
Yeah, before that, I want to thanks all of you,
Yes,
because it is our time to give a vote of thanks to all of you, especially Dr. Meghnad, Dr. Venkata Reddy, Dr. Pawan Singhal, and Dr. Dhruv Rai for making this program a real successful one. And I think for last 7 days you are coordinating with each other to making this program.
How many viewers are there?
300 we just recorded. I think more now. I have to just get you the details after some time. And also thanks to all the doctors who are attending over all India. I think it has been a great show for all the doctors attending on the Saturday evening, this program. And all my colleagues, especially Mr. Rajesh, Vinod, Suresh, and Bikash for making this program a great success. And Mr. Rajesh taking the logistic part so strongly. I think really thanks to all of you. And as a responsible organization from Bayer, Doctor, we all thank you and fight during this difficult time of COVID. I think you are in the front, that battlefield in the front as a fighting against this and saving all our life.
Without guns. Without guns.
Yeah. It's more than that.
Yeah,
and
maybe
really,
not very effective guns.
But really salute to all of you. Really salute to all of you. And as a responsible organization, Doctor, we also think, and this message to all India doctors, that wherever any patient of yours should not feel that we are away, and if they are not getting our product like Alaspan or Alaspan AM or Alaspan AG syrup, please let our colleagues know that we are there to ensure all our products are available to serve every single patient. So thank you very much. Once again, a great evening.
Thank you,
and have a wonderful.
Thank you.
Yeah.
Thank you once
Thank you,
again.
Mr. Rajesh. Thank you
all.
for the opportunity. Thank you.
Thank you all.
Thank you,
All the team.
Goodbye, Dr. Meghnad. Good
Here.
night. And good night, Dr. Venkat, Dr. Pawan. Good night. Have a
Good night.
Great, sir.
great weekend. Thank you.
Thank you, Dr. Pawan. Thank you, Roy. Thank you, Venkatram. We thank all the team of Bayer who have made a lot of effort. I know this is not a simple job. It's a very, very tough job. You must be working every day, 8 hours for the last 1 week. You have to make a lot of rehearsals, contact, coordinate. I know this is a very big job. Thank you, all your colleagues, Mr. Tuhin and Suresh and Rajesh. Thank you.
Welcome, sir. Welcome. Thank you very much.
Thank you.
Bye. Bye.
Thank you, everyone.
Good night. Good night.